أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آमीन। शुरू अल्लाह के नाम से जो नहायत मेहरबान और बहुत शफीक है। तारीफ़ तो है ही अल्लाह के लिए जो दोनों आलमों का रब है, जो रहमान भी है और रहीम भी, और यो यौम जज़ा का मालिक है। ए अल्लाह, हम तेरी इबादत करते हैं और तुझी से मदद चाहते हैं। ए अल्लाह, तू हमें सीधा रास्ता दिखा, उन लोगों का रास्ता जिन पर तूने इनाम फरमाया, और उन लोगों के रास्ते से बचा जिन पर तेरा गज़ब नाजिल हुआ, जो गुमराह थे। Ladies and gentlemen, we welcome you all over here today in this scientific session. The topic of this session is recent trends in management of wet AMD, diabetic macular oedema, and macular edema due to retina vein occlusion. First of all, I'll request Dr. Farooq Afzal, ophthalmologist at Shifa International Hospital, to just say a few words as an introductory brief. Dr. Farooq Afzal, please welcome the audience.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Welcome everybody to this scientific session. This is being hosted by Shifa International and Novartis, and most of all, there are good speakers to inform us about the latest trends in these retinal disorders. Long ago, we used to rely exclusively on the fundus fluorescein angiography, which gave us some details of vascular disorder, abnormalities of the retina. Then OCT came along, and as OCT progressed, the resolution and detail of the study went down to few microns. The things are changing very rapidly, and we need to stay up to date with it. An effort is being made by the guest speakers now, and after that we'll have an open discussion. Anybody who wants to talk or discuss is most welcome. Once again, I'll thank you all for sparing your time and coming along. Thanks very much.
Thank you, Dr. Farooq Afzal Sahab. Now, I'll request Dr. Amir Awan, consultant ophthalmologist at Shifa International Hospital, to give his presentation.
Assalamu alaikum, everyone. I'll talk on the management of wet AMD and macular edema due to retinal vein occlusion. So my disclosures. So I'll start with wet AMD first. So we all know that AMD is one of the leading cause which causes legal blindness, and around 10 to 13% all over the world, wherever or whichever community you have a look, almost same percentage are getting affected above 65 years of age. And we all know that since anti-angiogenic therapies have come up, that has revolutionized the treatment, and we have got the treatment for the first time, which we were looking for the long time. But if you look at the real life situation, it's not similar to the trials, because in the trials, mostly the treatments were given in the form of monthly injections, which again in the practical life may not be possible, and we may not get the same benefits. So Dr. Farooq briefly mentioned about the investigation. So OCT, the first important investigation which we would like to have before proceeding with the management. FFA, fluorescent angiogram, that's really helpful to identify and classify it. ICG, again in selected cases of wet AMD, ICG has got the great role. And even fundus autofluorescence, which also give us idea about the sick RP, and especially to get idea about geographical atrophy. That's a very useful investigation. So briefly, I'll talk about the classification. Type 1 CNV, which also known as the occult CNV. We can see that there are some hemorrhages here, but we're not seeing much well-defined. But if you look in the fluorescent angiogram, and that's arteriovenous phase, so we start seeing some leakage there. And later, that leakage keeps on increasing, but there is no particular pattern we are seeing here. So that's occult CNV, and we can clearly see on the OCT that it's lying beneath the retinal pigment epithelium. So that's choroidal new vessels which are growing beneath the retinal pigment epithelium. Type 2 CNV, which are known as the classic CNV. So we all know that those grow under the sensory retina, and we are seeing here the hemorrhages and a grayish membrane-like lesion we are seeing here, which if you look at the fluorescent angiogram, so that's arterial phase we are getting, and we are seeing the well-defined lacy network which is coming up here, and it's surrounded by a hypofluorescent area which is related to the hemorrhages. That leaks further in the later stages, we can see here. And even on the OCT, we can clearly see that this is lying above the retinal pigment epithelium. So we can see macular edema as well as choroidal new vessel, which is classic growing up there. When we were treating with the photodynamic therapy, at that time, the classification and the component lesion size was really important. So classic CNV was defined if it's greater than equal to 50% lesion, it was predominant classic. Minimally classic if it's less than that level, combined with the occult CNV, or occult without classic if there is mainly the occult component, there is no classic CNV at all. So just example of minimally classic, you can see here, so that's a whole lesion, and that's the area where the classic CNV is there. So we are seeing here, but that's a whole component. So that leaks further in the later stages, we can see here clearly. And then again, retinal angiomatous proliferation is really important, especially if you're getting the cases where you're not getting appropriate response with the treatment, you should consider it. And here, basically neovascularization begins at the retinal level and then proceed towards the choroid. And ICG is really helpful to get idea about it. So either we can see the intraretinal hotspot, or that's further extending in stage 2 and 3 hotspot within or beneath the retina. And there can be associated sensory pigment epithelial detachment or vascularized PED. So here we can see in the fluorescent angiogram, we can start seeing that there is some leakage starting to happen, and the vessels are dipping in, which are more defined here. So you can see that these vessels are dipping in the retina, and they leak over at the later phases. So here, if we have a look at the more highlighted view, we can clearly see that wrap lesion here, which is well defined and seen here. So that's another example. You can see hard exudates, you can see the tiny hemorrhage, and besides that, hard exudates and intraretinal edema you can see. So here the leakage keeps on going, increasing at the later stage, and further later frames you can see further leakage. So even in the OCT you can get an idea. So you can see that it's connected there. So you are seeing the intraretinal edema, and then there is a small area of the PED, so that's all attached with it. So that again specified that's a wrap lesion. IPCV, choroidal vasculopathy, that's again very important. And it's basically branching in the large choroidal vessels, which you are seeing here with the terminal endings. And that demonstrates in early, and it's very intense and multifocal leakage on ICG. So in one study, they concluded that it's around 8% of all CNV. And if wet AMD is suspected and you have got these risks like non-white people, peripapillary CNV, no drusen or AMD in other eye, you may suspect it in those cases. So just example, so this is the area where we are seeing the hemorrhages with some exudation. And when we look at the fluorescent angiogram, we can't see the exact detail of the, because it's at the choroidal level. ICG is a better investigation. So we can't, we see that masking and some leakage there, but if we do ICG, we can clearly see the dilated choroidal vessels here. So that's a magnified view, and we can clearly see that that's the level where the choroidal polyps are formed. So let's come to the treatment, which is really important, and that's why we are here for. So first, and the treatment of the choice, anti-VEGFs. So let's have a look at the what anti-VEGF agents we have got. First of all, ranibizumab. So mostly the studies which we will have a look here, they are conducted with this treatment option. So first and very important, Retina investigation. We all know that was in minimally classic and pure and occult CNVs, and that for the first time we were able to demonstrate that most of the patients, above 90%, are able to stabilize their vision in comparison to the control group. And they were maintaining, they were losing less than 15 letters. And again, around 33% of the eyes in this group, they showed greater than 15 letter improvement on ETDRS, which even if you look further, 42% ending up with 20/40 or better vision, which is a really good outcome, which we were not getting with the photodynamic therapy. Similarly, in the anchor, that has clearly shown with the both doses, 0.5 or 0.3 milligram ranibizumab monthly, that showed significant improvement, and the patient achieved around 11 and 8.5 letters again. Whereas in PDT group with verteporfin, there was a reduction in the vision, and they lost around 9.5 letters. So again, that has confirmed the Retina finding that 90% of the patients are able to maintain their good vision. Another study which I would like to highlight, PEER and EXCITE, in which we know that initially we give monthly injections. So here it was tried that if we switch over to the quarterly treatment, so we extend the treatment to 3 months, and let's see that how the effect will be. And that clearly showed that it's inferior to monthly dosage. So most of the trial, if you look for 12 months, 24 months, they were giving monthly injections, and here they tried to compare it with 3 monthly, and clearly showed that it's not. So here if you look here, in this, so we can clearly see that the patients who were receiving the quarterly treatment, they were getting more percentage of the visual loss in comparison to the monthly group. Pronto, that's again an important trial where 3 monthly injections were given and the PRN treatment later. So depending on the activity, either central retinal thickness was increased, is there any intraretinal edema present, any new macular hemorrhages, visual loss greater than 5 letters. So all things were kept in mind to have a look. And that again at 24 months showed that visual acuity improved by 11 letters, and the central retinal thickness was significantly reduced. So here if you look, around 43% of the patient had 15 letters or more improvement. And the SEALER study is again similar. But important thing is that the number of injections is less in comparison to the Retina anchor where the monthly injections were given. So CAT again, that was head-to-head trial between ranibizumab and bevacizumab. But if you look here, at 12 months, the patients who were treated with monthly ranibizumab had 11.7 injections, whereas with as needed treatment, less number of injections. But if you look at the visual gain, that is almost comparable. There is a slight difference, but still it's comparable. And even over 2 years, the similar pattern was seen. So we know that PRN treatment also works and gets a better improvement. SCURE and Horizon, these were the extended trials related to the Retina and anchor, and they basically established the safety at the long term, at the 4 years, that this is the safer treatment, it's not causing much damage, and it has also proven the efficacy. But if you look here, overall, there is gradual decline in best corrected visual acuity by around 7 letters, which explains that this disease activity keeps on going. It's not stopped with the injection. So what you're trying is, you're trying to control it. Still, you need to keep monitoring your patients. If you won't monitor, so these were the patients which didn't attend the follow-up at the time, or they were not given the treatment at the right time, so they were started to getting reduction in the vision. Harbor, that's one of the only trials which basically use spectral domain OCT monitoring PRN regime in comparison to the monthly treatment. So which was really important. And if we look here, it's a 12 months efficacy of 0.5 and 2 milligram dosing of ranibizumab. And if we look here, if we see that that's a 0.5 milligram ranibizumab, which is up here, and the second we can see that this is 2 milligram monthly. So we know that the monthly is slightly superior, but again, even the PRN regime, that's quite comparable. So not much drop in the effect you do get. So PRN regime really helps. Again, treat and extend. So that's another concept, is that we treat the condition and then we can extend the treatment. So we can extend from the 2 weeks going up till the 12 weeks. And if the patient starts to getting activity again, we can again start reducing the weeks. And that again has shown that the baseline vision is around 9.5 letters after 12 months and around 8 letters at 24 months respectively. And on average, if you look at the injections, first year patients were having around 8 to 9 injections, and later in the second year, they were having around 6 injections. 7-up, again, is 7-year follow-up. So we, as I mentioned, the peering side, that was up to 4 year. And that also showed that 1/3 of the patient were maintaining the good vision, but 1/3 of the patient were losing vision. And that again relates to the complex nature of this disease, which keeps on going. And here they also find that geographical atrophy, that also keeps on increasing. And that was the reason monthly injections, we were thinking that is it a good idea to give that, or we should move to the PRN regime. And that study has clearly shown that geographical atrophic area does increase with the monthly or intravitreal injections. Safety is an important concern. So that's a study where basically they measure the serum level of the VEGF, of the anti-VEGFs. So if you look here, in comparison to the ranibizumab, 13-fold increase even with the Eylea aflibercept. So, but if you look with bevacizumab, it's a 70-fold increase in the amount of the anti-VEGF in the body. And that explains there are some case reports, patients were treated with bevacizumab in one eye, and they had reduction in the CNV in other eye as well, which explains because of that fact. So it's really important when we are recommending the treatment, we need to have a look at the safety profile. We need to have a look at the cardiovascular risk factor patient is having, and that really helps us to decide about what treatment choice we are going for. So let's quickly come to the bevacizumab group, the CAT, which was one of the landmark trial. As we all know that off-label Avastin or bevacizumab was used for a long time, so we need to have some proof that it does work, and that has shown that it's quite comparable. It's non-inferior to ranibizumab. And here we can see around 8-letter improvement, 8.5 letter again. So here we can see clearly here, so monthly, they compare the monthly and as needed one. So here the blue and the red we are seeing, it's a monthly regime with ranibizumab and bevacizumab. Those were superior in comparison to the as needed, but again, the results are quite comparable. Ivan, again similarly, that was a comparison between both, and that again has shown that it's non-inferior. Bevacizumab is non-inferior to ranibizumab. Briefly about aflibercept, which is licensed in a lot of the country. Pakistan still it's not licensed, but we are hopeful that soon it will come up and license here. But off-label use, a lot of us are already doing it and getting the good response. So view studies, very important. So here we can see they compared with the ranibizumab. So initially they give 3 monthly doses, and they compared with the ranibizumab monthly doses, whereas in aflibercept group, they were given then at 8 weeks interval. And if we compare here the primary endpoint maintenance of the vision, it's quite comparable. So here we are seeing ranibizumab and here VEGF trap in different concentration or different dosage regime. It's quite comparable. So up till 8 weeks we can give and we can achieve the similar results. If you look at the secondary endpoint, that improvement in the vision greater than 15 letters at 52 weeks, again it's comparable to ranibizumab. We can clearly see here all VEGF trap eye groups are quite comparable to it. And if you look at the total number of injections, that makes a lot of difference. So here, if you look in the ranibizumab group, we can see around 16 injection, whereas in when we are giving at the 8 weeks, it's around 11 injection it's coming up. And that was at 96 weeks. Other treatment, laser photocoagulation, which used to be mean choice of the treatment for extrafoveal CNVs previously when we were in PDT era or before that. Here the landmark study was the macular photocoagulation study group, which showed at that time we were trying to reduce the loss. We were not getting achievement in improving the vision. So here we can see that if we look at 30 ATDRS loss occurred in 46% of the treated patient as opposed to 64% in untreated eyes. Photodynamic therapy, which again we know that it's a vertiporphin we inject and we then show the laser that activates it. And again, what we showed that we reduced the number of the loss in the patient. We were not getting improvement much even in the, if you look at the TAP and VIP trials, which were for either predominantly classic or occult CNVs, we can see clearly that 59% treated eye loss, less than 15 letter over 2 years versus 31% in the sham group, where just no actual treatment was given. Radiation therapy, briefly I would mention, that's not important at the moment, but the main try by doing it to reduce the number of the injections. And there are two ways. It can be either epimacular brachytherapy, in which vitrectomy is done and then the radiation is directly shown over the macula, or IRA system, which is stereotactic treatment. Cabinet and Meritage are the important trials there. Surgery, again, macular translocation, choroidal patch, they are very less frequent. Only people are doing in the selected cases where the patient has not got a good vision in the other eye, and it's just a navigation division they want to have. But submacular hemorrhage, that does commonly happen in CNVs. And that we'll discuss later, that what could be the recommendation. So just quickly go through what choice of anti-VEGF we should have. So we have got the three options here: ranibizumab, bevacizumab, and hopefully aflibercept as well soon. If you look at the ESRS survey last year, that clearly showed that around 78% are using the treat and extend protocol. And only 2% are using, which mostly trials were doing, the monthly treatment. And around 16% were doing monthly treatment and then treating according to PRN for active leakage if there is active leakage or vision is going down. So monthly, PRN, treat and extend. So I think monthly, mostly it put quite a lot economic burden, but we have to see the condition. There are some type of the CNVs in which you know that they will require more injection. So initially, yes, you do 3 injections at a month interval and see how the response is that. Either you can go PRN then, accordingly, that if there is no leakage or anything, but you need to keep monitoring the patient. You can't leave it like you treat it, patient comes after 6 months and then the activity starts again and then you have to start from the scratch. Or you can go for treat extend. Treat extend is especially helpful if somebody has having the recurrence of the CNV, so you can treat it and then you can extend the treatment accordingly. Non-responders, that again, it's not very common, but you do get the patients which are not responding to the one of the anti-VEGFs. There is another concept, tachyphylaxis tolerance. Tachyphylaxis, usually we say that if patient had response previously and now they started to having no response at all. Or tolerance, where response is getting reduced now. It's not as good as it used to be previously. Dosing regimes. Again, dosing regime, usually we try to go for monthly, but there are some cases in which if you see that the response is coming, but it's not actually as good, you can come up till 2 weeks as well. And even we can see in some trials, they move to the higher dosage as well, like 2 milligram was used in ranibizumab group. So that can be tried as well. Well, switch over, that's another important concept. If you're not getting the response or the response is getting reduced, you have to consider in mind. So this is the patient who was treated initially with bevacizumab. So there is significant intraretinal edema we are seeing here, even subretinal fluid is there. Patient had a good response with the 3 injections. There is few cystic spaces there, and then fluid started coming back again. And even the patient was treated again with the bevacizumab, there was no response. So this patient was switched over to ranibizumab, and that clearly dried up the fluid. So there is a good response. So you always keep in mind that you may have to switch over to different conditions, different treatments. So that's another example. That's the basal patient. You can see that there is subretinal fluid at multiple area. There is a large PED here as well. And that patient responded initially to 3 injections of ranibizumab. PD didn't go away completely, but much reduced, and subretinal fluid is gone. But later, fluid persisted, and you can start seeing subretinal fluid coming back again. And even treating that patient with further ranibizumab, no response. Now the patient was switched over to bevacizumab at this level, and good response. All subretinal fluid is gone. Some serious PED is there, but patient has got significant improvement in the vision. So briefly mentioning about the laser. Again, laser or PDT, very selected cases which we are doing. IPCV, especially in those cases, PDT has got the role. Low fluence PDT has been tried, and that has shown the efficacy. You can go for the combination therapies, because we know that only with the anti-VEGF you may not be able to get rid of the polyps completely. In those cases, you may start coming leakage again, so you can combine both. Peripupillary CNV, you can do the laser. Extrafoveal, in selected cases, like well, it's very less likely that somebody will be pregnant at that age group, but sometimes there are other forms of the CNVs which are happening in which you don't want to use the anti-VEGF agents. You can consider this option. So just to show IPC pre-PDT, we can see that there's some hard exudate leakage here, and there's some leakage, and you can see the polyps at ICG. And once treated with the PDT at 1 year, you can see that the polyps are closed, all the leakage is gone, and patient had improvement in the vision. Surgery, again, I'll briefly mention about. So if submacular hemorrhage is there, you want to have either pneumatic displacement, you can inject the gas within, and intravitreal anti-VEGF can be injected, or you can go for vitrectomy option. You can do vitrectomy, you can inject intravitreal Avastin or ranibizumab and put the gas and suggest the post-string to mobilize that fluid. Subretinal TPA is another option, but unfortunately in Pakistan it's not available. So let's all that about the wet AMD. Now I'll quickly move to the macular edema due to vein occlusion. So we know that the retinal vein occlusion is one of the leading cause after diabetes, which can impact the vision. And VRV is 2 to 3 times common as CRVO, usually happening in the middle age and elderly people. A classification, central retinal vein occlusion, VRV can be further into major BRVO or macular or minor branch retinal vein occlusion, or even sometimes the peripheral retinal vein occlusion can happen. Hemiretinal vein occlusion you can classify separately as well, but it also considered as the part of the BRVO. Diagnostics, again, OCT, FFA, very important. So here we can see that there is BRVO here with the leakage, and there is edema over here, fluid as well as hard exudate, and there is some blockage here which may not be clearly seen, but here the vein was occluded. So when we do OCT, that's a clearly defining, so we can see the hard exudates there. If we go this way, in this OCT, we can see hard exudates all there, not much fluid. But in this way, we are going from inferior to superior, and you can see that the hard exudates are coming up here, not much fluid. So first, we'll talk about the macular edema due to CRVO. So there are a few landmarks trials which are there for a while, but it's good to refresh ourselves. A SCORE, which was about the corticosteroids, basically they compared 1 milligram with the 4 milligram dose of triamcinolone intravitreal, and they showed that both results were quite comparable for 1 milligram as well as 4 milligram. But of course, there is a risk of cataract, there is a risk of raised pressure, but that was less with 1 milligram. If you look at the Geneva, in which is the Ozurdex implant, dexamethasone implant, they looked at 2 concentration, 0.35 milligram and 0.7 milligram, and they again showed that there is significant improvement in comparison to the sham group. A cruise trial that was about the ranibizumab, that again showed significant improvement. So we can see here with the both doses, 0.5 milligram, 0.3 milligram, around 12 to 14 letters improvement you are getting in comparison to the sham group. Well, there are no direct trials related to that, but a few people have tried, and they have shown the similar effect with bevacizumab, and the patient achieved quite significant improvement. Around 60% had gained 15 letters or more at 24 weeks. ILIA, that again, we know that the Galileo and Copernicus trial are there. And that has shown that significant number of the patients are gaining 15 or more letter. So here, what they basically did is initially for 6 months, they treated either with a sham or active treatment with aflibercept. And later, they basically combined sham with PRN. So patients were having aflibercept injections as well, and we can see here some 30% were getting improvement. Whereas the active, which were treating initially, as well as PRN, they have further, so coming up to 55% of the patients. And similarly, if you look at the week 100, again, there is a good response. Whereas in the Galileo, it's slight difference. For 6 months, they treated in a similar way, but later the sham group yet didn't treat, whereas the active group had the PRN treatment again, and we can see the difference 32% and 60%, which is shown here. BRVO, again, score BRVO, we know that's there. That has not shown much difference in comparison to the laser treatment, but it's almost similar, around 29-27% of the patients in that group. So the laser is an option, but if you look at the steroids, they have the same impact. Geneva, again, it has shown significant, similarly either in CRVO or BRVO, they have shown significant improvement. But the problem with Ozurdex is the effect is temporarily, usually 2 to 3 months. It doesn't last up till 6 months as they have claimed. So it's a reduced effect, which again people argue that why not to give then intravitreal triamcinolone instead of giving the Ozurdex implant, because both works in a similar way. Bravo, again, if you look at the Bravo, that's a ranibizumab study, and that has shown clear improvement. So we can see here around 16 to 18 letter improvement in comparison to the sham group, which has just a 7.3 letter. There is another important trial, Vibrant trial, with aflibercept, which has shown that 52% of the patients who were treated with intravitreal aflibercept in comparison to the 26% in the laser group. So there is a significant difference we are seeing here. And if we look at the 6 months, 17 mean improvement of baseline was 17 letters in this group in comparison to only 7 letters in the laser group. So just quickly go through recommendation, and I'll then pass on to Rahman. BRVO, again, macular perfusion is important, but to be honest, the treatment-wise, not much difference. So intravitreal anti-VEGF would be the first choice, considering all the clinical trials and the effects which we see intravitreal steroid. And even the laser to the peripheral retinal, if there is ischemia present, you need to treat it. So you do get the clues about that by looking at the fundus. If you suspect further, you need to do fluorescein angiogram, and that gives you an idea. So again, ischemia-wise, almost similar, but again, the steroids may be the better option if there is macular ischemia there, because theoretically we know that the anti-VEGF is causing further ischemia. And the laser we can do to the peripheral retinal area. CRVO, again, similar choice, intravitreal anti-VEGF, intravitreal steroid, and the laser. Especially in the CRVO, it's really important to get idea about the ischemia. Until the time ischemia will remain there, it will keep on releasing the VEGFs, your response will be the temporary effect. So you need to do the PRP to treat it, to treat the peripheral area, to get rid of the fluid for longer time. And similar way in the macular ischemia, we can. Surgery-wise, again, radial RON, they were quite famous at some time, but we know that the vision-wise, not much improvement. We do get rid of the hemorrhages. Fundus picture appears quite better, but visual outcome wasn't the great. Chorioretinal venous anastomosis, that again with the laser we can create. Vitrectomy, that again we know that vitrectomy has got the role either with or without ILM, and people argue in the way that it improves the oxygenation. And also if there is a tractional element there, you can release it. And Rahman will discuss later about the VMT classification on the OCT, that's really important. Injection of the TPA directly into the lumen, that's again a very fancy treatment, that can be done as well. Or arteriovenous sheathectomy in branch rectum vein occlusion. You basically connect, you remove the obstruction there, so they have got the combined sheaths. You try to reduce the compression over the vein. Thank you very much.
Thank you, Dr. Amir Awan, for your very informative presentation. Now, the next presenter is the one who has come from all the way from Karachi just to give the presentation in this session. So I'll request now Dr. Rahman Siddiqui from Karachi, Shahzad Eye Hospital, to please come over and give his presentation. Thank you.
Assalamu alaikum everyone, thank you very much for coming. Just going to connect my computer. While I'm connecting, if somebody has a question, we'd be happy to answer.
Why is it like in few cases we see a listing not working properly, but when we change it around, the other products?
Okay, I think it works both ways around. The switch is not that the Avastin doesn't work and the Lucentis or Eylea works. It's just that the fact that the Avastin came first, so we have used it in patients. It's cheaper, so we mostly use it in patients. And then we have Lucentis or Eylea, because they're more expensive. Sometimes we try it as a second-line medicine, and they have become available later on after Avastin. So a lot of the case reports that you find, you would see that people reporting non-responders to Avastin who has responded to Lucentis, or non-responders to Lucentis who had later responded to Eylea. So in my personal feeling is that it actually has to do the time frame, how these drugs became available, rather than a particular anti-VEGF. Because as you've seen in Amar's presentation, one of the cases was not responding to Lucentis, which started responding to Avastin. And part of it is probably has to do with tachyphylaxis. So if you use the same medicine in a particular patient, they probably develop antibodies against that anti-VEGF, and they don't respond. And some people keep switching the medicines. People who require lots and lots of anti-VEGF. You give one anti-VEGF 1 month, the other anti-VEGF the other month. So that's what I think is it.
Has it got any role in the size of the molecule? Or?
I think, I mean, in theory, yes, but I think the important thing is that what we have seen in trials. Personally, I am a firm believer in randomized controlled trials. I look at all the molecular size and the theoretical benefit. I would like that to be translated into clinical benefit. I would like to see a randomized controlled trial coming and showing that one anti-VEGF is better than the other anti-VEGF. And if you look at the major trials in wet AMD that were sponsored by the governments rather than the pharma industry, have shown no difference. So I'm a bit skeptical. I'm sure there may be a minor role of this happening, but until there's a randomized controlled trial proving this theoretical or molecular benefit, I would just kind of keep that in mind rather than translate it into patient care.
And you have tried Eylea?
I have, yes.
In Pakistan?
Yes, since 2013.
And have you tried the insert from Oedema?
No, I haven't. No, I
I
haven't.
have tried that, mixing it up with Avastins.
Uh-huh.
Occlusion or wet AMD before?
Sorry, I'm talking about like resistant CRPOs.
Mhm.
So those ones I really get good results.
I think the more injectables there are, it's good for us doctors to have that choice to give patients different medicine that we can. Right, so I'm just going to move on with a topic that is probably dear to us all, and that's the diabetic macular edema. Many people in the audience regularly deal with diabetic macular edema? Just by raise of hands. So quite a lot of people actually deal with diabetic macular edema, and I think it's one of the problems that we use anti-VEGFs commonly. These are my disclosures. I've received travel or research support. However, I have no financial interest relevant to this talk. I'm just going to delve directly into the management of diabetic macular edema without going into the epidemiology, because I think most of us see these patients, so we know that this is a common problem. And starting with diabetic macular edema, it's a systemic disease. So really we have to emphasize on ABCs of diabetic retinopathy, A standing for HbA1c, B is the blood pressure, C is cholesterol, and always ask for smokings. The thing is that if a patient walks into the clinic with an HbA1c of 8, do you think there's any benefit of actually dropping that HbA1c to 7.2, 10%. What are the thoughts? What would happen if we decrease the HbA1c by 10%? How many of us actually remember this, that if we drop this from 8 to 7.2, what we are doing is actually we're decreasing the risk of diabetic retinopathy by 40%. Progression to vision-threatening diabetic retinopathy by 25%, need for laser therapy by 1/4, and blindness by 15%. So when I see a diabetic patient, the first thing that they get is this. So they really need to get all these things in order. I don't like people saying, well, I've checked my blood sugar this morning, it was under control. I just say that this has nothing to do with me. I'm not interested in RBS. You know, random blood sugar is between you and your diabetologist so that he can monitor your blood sugar on a day-to-day basis. I'm interested in HbA1c. And I also look for anemia. Because if there's already ischemia and the patient has low hemoglobin, it's going to cause further damage. Lipid cause direct endothelial damage, so I'm interested in what their lipid level is, and also because it has an important role in exudative maculopathy in diabetic patients. Now, I'm also interested in microalbuminuria because when you see some of these patients, the results is in thousands, and they're not aware. And I recently did a cataract surgery on a patient who came to me 2 years ago with diabetic retinopathy, and I asked him to get all his blood tests done, and his microalbumin was in thousands. And he came back a couple of months ago, and he's on dialysis. So the microalbuminuria does not only predict nephropathy, but it also tells you about the risk of myocardial infarction or stroke. And once we have looked at all these systemic factors, which I emphasized quite a lot, then what are the treatment options that are available to us in 2015? So we have injectables such as anti-VEGF and steroids. We also have laser treatment, and we also have pars plana vitrectomy. Because it's a common disease, we have lots and lots of difficult classifications. Okay, this classification that I'm going to talk about, how I deal with my patient, is not for you to use in the exam. Okay, in the exam, you really need to stick to the classic definitions that you've been taught as a PG trainee if you're doing your FCPS or FRCS. But I find it in my head very easy to sort of divide these groups to offer them treatment which I think is most beneficial. So I have divided these groups on the basis of OCT, and there are 3 major patterns. One is focal diabetic macular edema. The other is cystoid macular edema involving the center of the macula plus minus neurosensory retinal detachment. And then there's vitreomacular interface abnormalities like epiretinal membranes, vitreomacular traction, taut posterior hyaloid. And initially when I see my patients, I usually get both OCT as well as fundus fluorescein angiogram. But in follow-up, I feel that OCT alone is sufficient. Unless a particular patient is not responding and you want to check for ischemia, then you need to repeat. So this is an example of a focal diabetic macular edema. So you can see that the macular edema is involving just one particular area of the retina. And this is not involving the center of the macula. It's not diffuse. This is a cystoid macular edema. You can see that there are full thickness retinal cysts involving, this is a cystoid macular edema with neurosensory retinal detachment. So this is the second group. And this is the third group with vitreomacular tractions. You can see there are thick membranes that are pulling the retina away from the retinal pigment epithelium. And then you can see really, really thick epiretinal membrane. So this is a diabetic patient with an extremely thick epiretinal membrane. He's not going to get better with whatever you're going to try. You know, you're going to try 1,000 rupees Avastin on 125,000 rupees Eylea. It's not going to work. You really have to do something about this patient surgically. So really, once you have divided these patients in 3 easy groups, I kind of come to the treatment options that are available. And let's just start with steroids. Most of us who deal with diabetic macular edema really like steroids because they're cheap, they're quick, and they work really well in most of the cases. And if you look at the studies, there are studies which support use of steroids, but the problem is that the benefit is really short-term. And the important thing with these steroids is really you need a long-term follow-up to assess their efficacy. and their side effect profile. I've been to meetings where people are talking about use of Canaccord in diabetic patients, 6 weeks results, 10-week results. This is just unacceptable because you really need to follow these patients up for 2 weeks. And if you look at DRCR protocol net, DRCR net protocol B, what you're going to see is the focal grid versus focal or grid laser versus IVTA. And what you're going to see is that at 4 months, you're going to see that 4 milligram does very well. At 12 months, there's no difference. And at 16 months, laser group actually does better. And most of us who are doing managing diabetic macular edema at the moment, laser is not something we really want to do to our patient because we know that it doesn't improve vision. So if you think about these patients receiving intravitreal Canaccord, who in the long run don't do well, they develop problems, their vision is not very good, but because we tend to lose our patients. When they don't respond, they go and see someone else. Then, they don't respond, they go and see someone else. We don't get to know what's happening with our patient. But trials are there to help us. And if you can see that the intensity of cataract is actually dose dependent. So the 4 milligram have 51% cataract at 2 years. And if you really follow them long enough, everybody develop cataract. So this is nearly 100%. And 1/3 of these patients will be on topical medications for glaucoma, and they require surgery. Now, before 2005, we didn't have many options other than giving laser and Canaccord, but now we have anti-VEGF, and we all know that diabetic macular edema is a VEGF-driven disease, and there are experiments which have shown that in the vitreous of the diabetic patients, patients who have diabetic macular edema, VEGF levels are high. And to compared to steroids, VEGF had a better side effect profile. But I think one thing that we really need to emphasize to our patients, because anti-VEGFs are angiostatic. They are not going to cure the disease. So they just treat the disease for the short term. Repeated injections are oftentimes necessary. So all these patients, I really have to emphasize to these patients that, you've got a condition which is not going to get better. You really need to get this treatment. This treatment was not available 10 years ago. It's available now, but it only works for 4 weeks. You need to really get this treatment repeatedly. And I think it's best you have this conversation at the first consultation, because the patient knows clearly what they're signing up for. Because the last thing you want is to telling them that you need 1 injection or 2 injection or 3 injection, then you repeat and you say you require another 3 injection, and then the patient gets upset because they think, hang on a second, you just told us that you need 3 injections, I'm going to get better. If you have this conversation first time round, they may go around and seek second, third, fourth opinion. Some may not come back, which is fine. Some may come back to you, but they know what they have signed up for. There are many trials for anti-VEGF, READ trial, RISE and RIDE trial for Lucentis. We have DRCR net protocol I, then we have DaVinci and Vista trials for Eylea, and then we have DRCR net protocol T. I cannot discuss all the trial because of the shortage of the time. I'm actually going to discuss DRCR net trials because these are non-industry sponsored trials. I'm going to talk about protocol I and protocol T. RISE and RIDE trial showed that Lucentis was better than standard of care. Similarly, DaVinci and Vista trial showed Eylea is better than standard of care. So as expected, there's no doubt about that. But if you look at the DRCR net protocol I, this is again a large trial follow-up of 2 years, which looked at 4 arms: patient receiving sham injection with laser, patient receiving immediate injection after getting Lucentis, and this was after 1 week, or patient getting deferred laser. So they received no laser for 24 weeks and they got laser afterwards. And then the last group was Canaccord with prompt laser, like within 1 week. So we have these 4 arms, and what it showed really that the anti-VEGF group, that the Lucentis group did the best. You had the one with laser, with immediate laser, or the laser that you deferred for 24 weeks, they did really, really well. The Canaccord group with the prompt laser, it's slightly better than laser alone. If you do subgroup analysis, there is this indication that in pseudophakic patient they did better, but this study was not powered to look at the subgroup analysis. But raised intraocular issues were quite common. And here is what we see, and this is why I have issues with the trials. So this is the sham group with prompt laser, so you're giving only focal laser to this group. This is the Canaccord group, and right at the top, both groups are the Lucentis group. And if you look at them right here, early on, 4 months, Canaccord group is right at the middle, and the laser group is doing worse. You follow them long enough, you see the Canaccord group is coming down, and the laser group is actually catching up. You follow them up further, and what you see that this laser group is constantly catching up, and these patients have developed cataract here, so their vision has gone down, and as they get cataract surgery, the vision starts to improve. But the groups that remain right at the top are the ones with anti-VEGF. Now, the good thing about anti-VEGF treatment in diabetic macular edema, unlike AMD, really in AMD you have to treat them forever, and I think we are lucky to have Dr. Usman with us today. He's the AMD lead in one of the NHS hospitals in London, and basically, the AMD treatment, once you have a patient, that's it. You have the patient. There are very few patients that you can actually cure. But what we have seen in these studies is that diabetic macular edema is a different disease. And if you see that the number of injections the patient received in the first year were the highest, second year they got less injection, and the third year they got even less injections. And this is the Lucentis with prompt laser, Lucentis with deferred laser. And there are some thoughts that maybe by giving laser treatment we can actually cut down the number of injections that we give to our patients. What is the role of Avastin in diabetic macular edema? We have protocol H, which has shown that it works, and the laser also catches up. We have the BOLT study from Moorfields Eye Hospital, which looked at around about 80 patients and followed them up for 12 months. I mean, basically, if you want to bring down the macular thickness and if you want to improve vision, anti-VEGF are the key. Now, this is the SuperCat study, the DRCR Protocol T. What it looked at Avastin, Lucentis, and Eylea in diabetic macular edema patients. It's a 2-year study, and basically the primary endpoint was at 1 year. And patient got 4 weekly injections in the first year, then they were followed up after 4 to 16 weeks. And basically they were followed up with OCT and EDTRS. The results were published earlier this year in the New England Medical Journal. And basically this is the design of the study. So we have aflibercept 2 milligram, Avastin 1.25. Lucentis is the lower dose, 0.3 milligram, which is approved by the FDA in the US for diabetic macular edema. And roughly equal number of patients who completed 1 year. And what we see, interestingly, is that if you look at the number of patients, the top one is the Eylea. Okay, so this is the main change in visual acuity for the whole group of patients. So the inclusion criteria for this study was the patient with a 20/32 vision or worse. Okay, so all these patients, if you look at them, Eylea had 13 letter gain, Lucentis 11, and Avastin 10 letter gain. There was a pre-specified subgroup analysis that they're going to divide patients with good vision, that is 6/12 or better, and 6/12 or worse. And they're going to see if there's a difference in anti-VEGF in these groups. So again, this is the same slide. And if we look at the patients with 6/9 to 6/12 vision, you really see that all these lines are coming together. So there is really no difference between Avastin, Lucentis, and Eylea when you're looking at good visual acuity. 6/9 and between 6/9 and 6/12. We do not know what is the outcome in patients such as 6/6, somebody who has really, really good vision. But if you look at patients who have visual acuity 6/12 or worse, these were the interesting findings. That Eylea had 19 letter gain, Lucentis has 14 letters gained, and Avastin has 12 letter gain. and you can see that the p-values were significant between these two groups. Then looking at the thickness, reduction in OCT thickness, Avastin performed poorly. We know this from CAT trial as well, that a lot of patients had intraretinal fluid at the end of the study in the Avastin group, and Lucentis and Eylea did pretty well. Now, if you look at the p-values, these p-values are significant, but there's no difference between Eylea and Lucentis. Well, there is 0.3. But again, the interesting thing is, if you look at the good visual acuity group, and this is the good visual acuity group, Lucentis and Eylea are similar. Avastin didn't do very well. And if you had patients with poor vision, you can actually see, if we had a patient with poor vision, Eylea did the best. Okay? This protocol T is going to be a very important study for times to come. Moving on to laser. Is there a role for laser? Should we just throw away our lasers when we have all these injectables? I think there are. And one is that diabetic macular edema, which does not involve the fovea. So it's a focal diabetic macular edema away from fovea. That's where I use laser. Patients who cannot afford, for logistical reason, for health reason, financial reason, to get frequent anti-VEGF. We know that laser does work. We have seen, initial trials of diabetic macular edema. It does work, but not as good as anti-VEGF. And sometimes in combination with anti-VEGF to reduce the number of injections. But if there are no restrictions, anti-VEGF is the best treatment, or the gold standard for diabetic macular edema in 2015. Now, I would like to emphasize the difference between a focal and a grid. Okay, when I do laser, I do not do grid laser. Basically, grid laser is just you're going at the macula with your lens and you're just firing away diffusely, not knowing what you're treating. Okay, what I mean by focal laser is you actually do a fluorescein angiogram, you look at the microaneurysm, you look at the microaneurysm that are leaking, and then one by one, you have that fluorescein angiogram in front of you, you actually treat single aneurysm at a time. So that's what you do. You look at the aneurysm in front of you and you treat them. You don't just blast away the whole macula with a laser and saying that, I've done a laser and the laser is not working in this patient, or actually it has caused vision loss. Whatever you do, don't do this or this. This is another patient. I think somebody's been firing indirect laser to the macula. And of course, these patients are going to do extremely, extremely badly. So basically, whenever we are doing laser, just a focal laser to the area of leakage, that's what's going to help. What's the role of vitrectomy for diabetic macular edema? I mean, there's a lot of discussion that, you actually increase oxygenation, you remove cytokines and all that kind of stuff, okay? And you may remove, you actually definitely remove traction as well. But for me, I think the important thing again is what is the evidence base for diabetic macular edema, for vitrectomy for diabetic macular edema. There's a very small group which has vitreomacular traction. I feel that group actually benefits, the group that has vitreomacular traction or epiretinal membrane or taut posterior hyaloid. This is a Tommy's study where they looked at 40 patients. These patients were randomized, but these patients did not have any visible traction. And when they looked at it, there was no difference. You give them laser, you give them vitrectomy with ILM peel, they have no difference. When the DRCR-net tried to do a study looking at the benefit of vitrectomy and ILM peeling in a group which has, visible vitreomacular traction, they had a problem. They were able to do studies of randomization of Avastin versus Lucentis, Lucentis versus Eylea, Avastin, Eylea, Lucentis, everything. But they were unable to find investigators who are willing to take part in studies where there's visible vitreomacular traction and they're okay to randomize them to a treatment arm where they will be giving injections or laser. So everybody wanted to do basically surgery. So there was a lack of equipoise, so they were unable to complete the study. They were unable to do the study. So instead of reporting a randomized controlled trial, they just reported a case series. And in this case series, there were 87 patients, and all patients had traction, and everybody received vitrectomy with ERM and ILM peel. And what you see is that the central macular thickness decreases over time in this cohort which received vitrectomy. However, vision didn't improve. And we also have to keep in mind that 1/3 of the patient actually lost vision in this group. It is possible that the issue is not the fact that these patients are actually have been tried with laser, tried with various anti-VEGF, tried with steroids, and by the time that they come to get the vitrectomy or referred to a vitreoretinal colleague, a lot of damage has already happened. So it is possible that if some of these patients, if we operate on them early, they may have a good outcome. We do not know. And those people who are operating, they know that the ILM peeling in diabetics is not similar to the ILM peeling in macular hole, which is very easy. The ILM is adherent to the macula, and while you're peeling, a lot of the time you actually induce separation of the retina from retinal pigment epithelium, which in some cases may be damaging to the vision. Now, the predictors of good visual outcomes are definite macular traction on OCT, short duration, no laser, degree of macular ischemia. You really don't want to be operating on patients who have macular ischemia, and the amount of exudation. The lesser the exudation, the better it is. So really, I think the thing to keep in mind, just like all men were not created equally, similarly diabetic macular edema were not created equal. And then I have these 3 groups, and I offer laser to the focal, diffuse foveal involvement injections, vitreomacular interface abnormality. I offer them vitrectomy and ILM peel. And I really have no issues with whichever injection patients want. I tell them that all injections are well, what is your choice? And if the patient gives me an option, I start with the cheapest injection and then move on to the next and the next. So this is an example of a focal diabetic macular edema. You can see that there are focal exudates here. You do a fluorescein angiogram, you see leakage. Okay, and then what you do, you offer laser to this patient, and you can see in this follow-up that the area of thickening is reduced. You can see some adhesion of vitreous here, but there is no traction, and this is a 12-month follow-up on the same patient. So the vision here is not clear. It was 6/12. And the vision is 6/7.5. Really, if we have started giving injection to this particular patient, by this time he would have received maybe 8 or 10 injections with the inherent risk of endophthalmitis, and vitreous hemorrhage and other problems and retinal detachment. And this patient received 1 single treatment of focal laser. This is a patient with diabetic macular edema. Again, there are some vitreous overlying the retina, but it's not causing actually any traction. This patient had haphazard injections. So he had 2 injections somewhere, 3 injections somewhere else. Then after 6 months, he'll go and see another doctor and another doctor. By the time he came to me, I just told him that you really need to get injections every month, at least for 12 months, and then we are going to have any chat of changing treatment or decreasing frequency. And, surprisingly, this is what the patient looks like after 1 year of monthly injection treatment. Same patient who had previous injectables did not, quote-unquote, respond. It's not actually the patient didn't respond. He just didn't get the treatment as we should have been giving in the trials. And you can see that stuff on the surface is lying there, but it's not causing any traction. This is another example of a patient with epiretinal membrane, which came to me earlier. I was just following her, then this epiretinal membrane started causing retinal thickening. This is the 3D OCT. And then this is the comparison after the treatment. So this is 13th of October, and this is 6th of November. You can see the traction went away immediately without any injectable in the eye, just by taking away the membrane. Now, whatever you're doing, always the back of your head, you should be thinking about the ischemia. Because if you look at this patient, how many of this patient, this is a central foveal thickness of 750 microns. Everybody agrees that this patient requires treatment. How many of you would consider doing a fluorescein angiogram on this patient? 1. So only 1, 2. Okay, so there are 2 people, 3. 3 people would consider doing a fluorescein angiogram. And once you're having a discussion with this patient about whatever treatment choices, steroids, giving them laser or whatever, what do you think is the vision going to be for this patient? This is the same patient. Complete non-perfusion. And when you look at the fundus, you don't see anything which tells you that this patient has got complete capillary shutdown. It's like, just a normal diabetic looking with, even sometimes less hemorrhages. And there is no blood supply whatsoever. And you're not going to grow that back. So I think it's important you have this conversation. And I usually, what I do is that I don't offer them injectable. I actually do a good PRP. Because this patient is just going to vanish. She's going to have 2-3 injections, then she's going to say, I don't know, doctor, but you're useless. Okay, so she's going to go and see someone else, and different people will offer him different treatment. Somebody will try drops, somebody will try something else, and this patient is going to disappear from follow-up, and then she's going to return with rubeosis. So best to give them good PRP. And you see, this is the same patient. You look at the macular thickness. So if you rely exclusively on OCT without thinking about ischemia, you may end up seeing some of these patients. So what are the medications that sometimes cause cystoid macular edema? This is something to keep in mind because, these medications are used in diabetics, and some common medications are these, glitazones. And these are used in our patients. Diabetologists love them because they bring down the HbA1c or blood sugar quite quickly, and patient has a good response. But they, as a side effect, they have a fluid retention. So these patients have fluid retention in their bodies, including in their retina, and they may come to you with cystoid macular edema. How do you know, or how can you differentiate whether this drug is causing the problem or the problem is unrelated to the medicine? One of the things is to look at patients' ankles. If there's fluid retention there, the likelihood is that this may be coming from the medicine. Because, we ophthalmologists try to focus just on the eyes. It's, you can just look at the swollen ankles of these patients and say, hang on a second, what medications you're taking? Because, if you stop them, some of them have remarkable improvement. What is the role of phenofibrate in diabetic macular edema? Okay, again, I think this is something really new, and we should all know about it. And if we are, discussing our patients with diabetologists, we should ask them to consider starting patients on phenofibrate. There are many. There are 2 major randomized controlled trials looking at this, and I'm just going to kind of say a summary here. Is that there's 30% improvement if you give them phenofibrate in diabetic macular edema. In field study, there was a huge number, nearly 1,000 patients. And here there's 5,000 patients in the ACCORD-I study. And it actually has effect on proliferative diabetic retinopathy as well. And the benefit is marked in patients with pre-existing diabetic retinopathy. So if somebody has no diabetic retinopathy, you don't need to say, take this phenofibrate and you will not develop diabetic retinopathy. No. Patients have to have diabetic retinopathy, and that's where the benefit has been shown. Number needed to prevent first laser treatment is if you treat 17 patients, you prevent 1 laser treatment. And if you treat 14 patients according to eye study, you prevent 1 laser treatment. So this is pretty good. Now, cataract surgery in diabetic macular edema, a common problem that we deal with. It has been shown that if you give these patients who already has diabetic macular edema at the time of cataract surgery, Avastin injection or anti-VEGF, they show benefit. I tend to treat diabetic macular edema first and then consider doing cataract surgery. And when doing the cataract surgery, I give this anti-VEGF injection. In normal diabetics, the effect is not as much. People who do not have diabetic macular edema and you're doing cataract surgery and you say, let's give anti-VEGF as well. I am quite concerned in these patients that you're doing cataract surgery and you're giving anti-VEGF most of the time, which is Avastin, of the risk of infection in the eye. So I would just rather do 1 procedure at a time because I don't want to be confounded by what we are giving them in the eye. Now I'm just going to discuss once the projector switches on 1 case, because we have to really think about, because diabetic macular edema is really common, and as you have shown earlier that most of us deal with this problem on a regular basis. We need to know some of those patients who are masquerading as diabetic macular edema. The other day I've seen a patient who has already received 6 Lucentis in each eye with diabetic macular edema. Now he comes to me with a problem that he also has, he has geographic areas surrounding the fovea which are missing, retinal pigment epithelium. Looking back at all his OCT, he did not have a typical cystoid macular edema picture. He has a problem of deafness, and he also has issues that his mother was diabetic. And in looking back, I've asked him to bring all his OCTs. I've never actually seen a real picture of diabetic macular edema in this patient. That particular patient had maternally inherited diabetes and deafness. Yes, he is losing vision, but he's losing vision to a particular kind of retinal dystrophy which happens to be happening in diabetic patient rather than the diabetic macular edema itself. Now this is a 58-year-old male doctor, came for a routine checkup. He's type 2 diabetic. His insulin is pretty well controlled. Blood pressure is reasonably okay. There's slight ankle edema, and the vision is pretty good. And this is what his fundus picture looks like. This is his right spectral domain OCT of his right eye. You see it's pretty okay. The left eye shows areas of hyperlucency. Okay. Now, in this particular patient, this OCT scan is not as useful as this EDTRS printout. And there's a catch in this EDTRS printout, which, if somebody knows what it is, I would like them to just shout it out. What do you see? What do you expect to see here which you do not see? Who said this? Asan. Yep, that's what it is. Right, and then you look at here, they've got these, weird kind of quote-unquote leakage, which is not a true leakage. Again, same patients, and this is a different cuts. You see these areas of hyperlucency. Again, just different cut and a different cut. And what you see here is that the outer retina is involved as well, the retinal pigment epithelium. And in diabetic patients, that's mostly not affected. Compared to what Amir was discussing, the AMD and diabetic macular edema is an inner retinal disease. AMD is an outer retinal disease. Diabetic macular edema, if you delay the treatment, it's forgiving. Macular AMD, you really have to treat early. So what would you do next in this particular patient? Because this patient has this peculiar problem, diabetic, looks like cyst. Patients, discontinued glitazones, ankle swelling improved. There was no change in OCT. Patient got Avastin, no change on his OCT. He got 3 Lucentis. And this was his OCT after 3 Lucentis. You can still see the problem there, okay? And if you look at macular thickness profile, as Asan has pointed out, there is no thickening, there's no red sign which you would expect in diabetic patient. Anybody knows what it is? This is basically MACTAL2. This happens to happen again in diabetic patients. These patients are not going to get worse. It's usually a bilateral disease, but because this was a doctor who was coming for a routine checkup, and because the OCT is now available routinely, we get to do these scans. And this is an early presentation. It is going to involve the other eye. And MACTAL2 has 2 kinds. One where there is a proliferative disease, which can show some response to anti-VEGF. The type where there is no proliferative disease does not respond. And it was an early presentation. So because this is a common disease, we are dealing with these patients on a regular basis, it is important to be aware of all these kind of patients who are taking medicines, who have retinal dystrophies that happen to happen in diabetic patients, or patients who have other diseases which presents in diabetic patients behave like diabetic macular edema. Thank you very much.
In your presentation, you mentioned that anti-VEGF may have some effect on the cardiovascular system. Are there some definite contraindications where this should not be used or should have detailed serious examination? Should be done before, so as to be on the safe side?
I think it's important thing is that when you're talking to this patient, you need to know what exactly the problem. Either patient has stroke or cardiovascular problems are there. And depending on that, you need to mention the patient that in the trials, we know that in comparison there is not much difference, but definitely the licensed treatment, that may be a better option in the way theoretically, as we were talking about, it's a small molecule. In the case of either ranibizumab or even Eylea, it's a smaller in comparison to the Avastin. So that can be talked about. Other thing you can, if you feel that the patient may not be, you need to look at the alternative options. What are the other alternative options? Like in the form of the laser treatment, if you're dealing with some diabetic macular edema and it's a focal, or you can even consider intravitreal steroids as well.
Right. Yeah. I think I have a slight different take on this. If you look at the studies of AMD or diabetic macular edema, even if you look at protocol T, the most side effects, cardiovascular events, were actually in Lucentis group. And if you look at IVAN trials, there were more side effects in the non-Avastin group. So the issue of side effect is there. We don't know why. We don't know why this is happening, why one particular group is involved. And the problem is that we don't know whether these side effects are real. Because the population, particularly in the AMD, the average age is above 75 group in the trials. So these patients are going to have different problems, including stroke, MI, and all these things. And I think once a patient has this problem, if there's diabetic macular edema, if you decide, you can actually delay the treatment a little bit, because as I mentioned earlier, it's a bit more forgiving disease. The problem is that if patient has AMD, you really can't delay the treatment, you can't leave the treatment. I usually actually just say carry on. I don't know, Usman, do you actually stop treatment with Lucentis if patient has a stroke or MI?
I think as we all talked about, we can't be exactly sure in that age group. Depending on that, how much side-threatening it is, you have to deal with it. But patients should have informed consent. They should know what they are dealing with. Either you are using Lucentis or using Avastin, so patient should know about that. There are risks there to some extent.
But we can give them alternative options, like we do give them an option of stereotactic radiotherapy, and we do give them options of PDT, even though patients might have classic CNVs. So there are options. There'll be people who'll say, Doc, I'll still want to have intravitreal injections, and there'll be people who'll say, no more injections, please. I just want to explore other options. And that's fair enough.
I think Professor Imtiaz wants to ask something.
While you're doing an anti-VEGF injection, if you get a sudden loss of vision, do you do a paracentesis?
You mean when you're checking for the hand movements, or I think never happened, but yeah, if it is somebody, usually in my practice we do check the pressures before that, how much the pressures are. If the pressures are raised, it's already flagged out. But I haven't come across myself, but yes, I would do. Similarly, I'll do AC paracentesis.
We did our, audit of intravitreal injections, and in 3,000 injections, we had to do about 4 paracentesis. And the criteria that we employ is if the patient doesn't get a vision of at least counting fingers 5 minutes after the injection, we would take the pressure, we'd get the patient back in, the patient doesn't go anywhere, sit them on the slit lamp, put some iodine in, stick a needle in, take the fluid out, and then take some fluid out and put some antibiotics. And they usually recover quite quickly from paracentesis.
So, Swan, you do this paracentesis on the slit lamp or in the OT?
We have a dedicated injection room in which we take the patient to. We take the patient into the other room, check the pressure, back in. The patient doesn't go anywhere, all work stops till the patient gets their vision back.
Yeah, in my practice, basically 2 things I would like to have: first, vision, pressures. So vision, always, whenever the patient is coming for injection, I would like to have vision, because that highlights if patient is having some further problem, any bleed or something happening, that comes up earlier. Another thing, even we check the pressure post-op as well. So once it's done, they will sit there and somebody will check with a puff tonometer, but it will give us a rough idea that what's happening.
Patient is developing fractional retinal detachment. Is still Western or anti-VEGF safe?
Well, that's quite a tricky. I think if the tractional element is there, usually my take is, especially even tractional element, vitreous hemorrhage, I won't suggest to inject Avastin. If you know that the traction is there, and that's why even with the dense vitreous hemorrhage, it's a good idea always to do the B scan to get idea about the traction. Because then we get the cases I have got, I'm sure Rahman same as well, very bad cases who had multiple Avastin, and that really affects further. So if there is traction, I would suggest no Avastin, please. But in some cases, like if it's a tractional element and it's a juicy vessels, I have to do the surgery. So within a week or 5 days prior to the surgery, I would give Avastin, but then do surgery, not for the purpose to treat the. Rahman, what do you think?
I think it's the same thing. I mean, patients who have tractional elements, especially close to the macula, I would be very, very careful of giving them anti-VEGF, because they sometimes lead to this Avastin crunch when all the blood vessels contract and their actually tractional detachment becomes worse. So if I'm operating on a diabetic patient with a tractional element who I would wish to give Avastin before surgery, I actually get them to get a clearance from GA before I give them injection. Because I don't want to give an injection and then the GA, they say, well, he can't have a GA, and then I'm in a problem. So I get them to have a GA clearance first, then I give them Avastin and then operate within 3-4 days. I'm sure Asen has seen similar cases where, patient gets lots of injection, tractional elements, and they become worse. Is that what you've seen as well?
Yeah, similar thing as.
I just want to add a bit of it that, with all these anti-VEGF agents, we are just trying to decrease the load of VEGF within the vitreous cavity. And it's a good idea to, as wide field angiograms are now getting in, just to have a wide field angiogram in these patients and then try to treat the source of that VEGF.
Absolutely.
Both in CRVO as well as diabetes.
Very, very important point. Yeah. So you need to keep in mind macular edema. It's just not. So there is a source there which you need to treat. And similarly, even in the recently, I had a patient who was diabetic, and patient had a vitreous hemorrhage. One of the colleagues thought diabetic vitreous hemorrhage, otherwise perfectly normal, no retinopathy, treated with Avastin. And basically, the patient had retinal detachment, that patient with the vitreous hemorrhage, and later was seen by someone else. So always look for, if you're not seeing the good view, maybe it's a good idea to do the B scan to see retinal detachment, it's there or not.
While prioritizing the investigations, we just put OCT on the first and then the fundus fluorescent angiogram. Okay, in the management part, while we are giving the injections, OCT should be the first. But while you are investigating the case to see occult class A and leakage and focal, etc., I think FFA should be the first.
Absolutely. I think in wet AMD, I would, even as Rahman talked about, even in diabetic macular edema, you're dealing, if you're suspecting that any element of ischemia, like the case Rahman is classic, the case shown, you need to have FFA. AMD, it's very important. You want to have, initially you want to classify, you want to know that what you are dealing with it. As I mentioned about polypidal or wrap lesions, these usually require more aggressive. So I've got the patient who has got the wrap lesion, and she requires more injection, monthly, a lot injections, and then there would be the response. So you can't decide only on the basis of the OCT. You need to have. Rahman?
I think FFA is still not, you don't need to throw away your FFA machine. First time in diabetics, it's best to get the FFA done. If you have a wide field angiogram or if you have access to it, definitely get a wide field angiogram, because that's going to be extremely helpful. But if not, then at least get the fovea and the area around the arcade. But in follow-ups, you don't need to get a fluorescein angiogram unless the patient is not responding or showing some peculiar behavior, to respond to treatment.
One thing while we're on the matter of recent trends, let's say that about diabetic macular edema, there are 2 or 3 things that are coming up, and one of them is non-contact lens laser, which is produced by ODOS. And the interesting thing is that we're finding that because it's an OCT-driven laser treatment, we're finding that the effectiveness of the focal/grid laser treatment is much more effective than conventional laser. We think that in future maybe less intravitreal injections might need to be given. There's also another thing called Iluvien, which I don't know whether you've had the experience of over here or not, which is a 3-year intravitreal drug, which is a steroid, fluocinolone. and which has given very, very good results. It's a very expensive drug, about £5,500 per injection, but from the injections that we've given so far, we've had extremely good results. So that's another thing to look out for as well.
That's great. Thank you very much. Thank you, everybody.
Thank you, Dr. Rahman Siddiqui and Dr. Amir Awan. And thank you, ladies and gentlemen, for your participation and active participation in the discussion. Now, I would like to invite as Mr. Aziz Ahmad Jan, Chief Operating Officer, Shifa International Hospital, for a vote of thanks. Dr. Jan, please.
Good evening and Assalamu alaikum, ladies and gentlemen. For a non-clinician, it was a very interesting topic for me this evening. Dr. Evan, thank you very much. Dr. Rahman, thank you very much. And Dr. Usman, thank you very much, although you are here and you are with us today. So, Dr. Farooq Afzal, thank you for arranging this event for us. Novartis, thank you for supporting us for this event. And one more thing is this, we are sitting at Islamabad hotel, so I would like to extend my sincere thanks for their logistics as well as when the patient comes to a hospital. Sometimes they feel the hospital, they are writing a letter for thanks. So likewise, we always participate in conferences, but we never realize these kind of activities. From Shifa International Hospital, I would like to thank you every single one for participating in these events, and we are trying to create a culture of knowledge sharing in all the areas of the different disciplines in the hospital, and we do conduct regularly the sessions so we can share the knowledge and expertise. This time, this was our All India in Islamabad chapter. Hopefully that we will be able to arrange more sessions in elsewhere, because in the bigger cities it's always possible for our consultants to get some chance to get to this kind of education. But one of the important thing is the people who are referring patients to you. What I have seen mostly, the complaints from the patient is that a patient and the doctors in the rural areas, they don't get a letter from a consultant and advice for a rural, a medical officer or whoever is the healthcare provider. If we can look into this era, that is going to really help. I work in UK. I was in NHS. I was a manager at the Birmingham Trust, and we were always looking into how we can manage the referral from primary to secondary physician and to the tertiary level. And I think in the developed world has helped a lot for that kind of the feedback which we are providing to the, and I will request that if we can consider that feedback to the people who are referring our patients from the rural areas or from the other facilities, that will help a lot. So thank you very much once again for being here, and especially Dr. Thank you very much all the way coming from Karachi. Thank you very much.
Thank you, Aziz Jan sir. And before we proceed for our dinner, I will request everybody to come over here on the stage for a group photo.